Siddharth, do you have any choice of incision based on what sort of clearance you're doing in the neck? Like you said, you prefer to go with the neck.
Yeah.
I mean,
I do a simple split.
Horizontal.
Yeah, horizontal with a split here. That's it. I will do MRND.
No, that's basically because it's fine. You gave a good exposure, so that everybody goes for it.
See, right now, once they are starting, when we started, I was working. So everywhere in a cancer institute, they used to do a Schobinger.
Schobinger, yeah.
Right. So the video which I showed of all the anatomy of the neck, that was a Schobinger incision. So what I said that you cannot do a laparoscopy if you do not know how to do a laparotomy. So if you only know how to do a small horizontal incision, you do not know actually what is happening deep inside, right? So what I think once you are starting, you should practice a normal Schobinger at least for 20, 25, 30 cases.
My intention was that for the beginners,
yes,
start with either a Schobinger or modified Schobinger.
Yes. Maximum cancer centers, they are still doing the Schobinger. With this cancer load, with a small horizontal incision, they cannot manage. Right? Even in the cancer center I am working, our few oncosurgeons are there, general surgeons, if they get the case, they will do a Schobinger. There's no harm in doing in anything if you get a good proper exposure. Even aesthetics matters a lot, that I know. But anyways, when they are starting, they should practice a normal Schobinger. Again, McAfee is difficult. It's a breech flap, right? Breech flap underneath bleeds a lot.
Do you want to give some tips regarding the tri-area radiate area?
Yeah, right. When you are doing a Schobinger incision, it shouldn't be on the carotids. Try to go a little bit behind, near the SCM at least. Because if this is a triangular, right? It might break off, especially in patients when they are going for radiation and all, right? And do not do the Schobinger incision when you are doing on a radiated patients or already the patients have been operated.
So yes, that part will be covered by Dr. Rahul Thakur. Okay, variations in incision will be covered by Rahul Thakur. We'll come to that.
Yeah.
Now, please understand, for a beginner, it has to be a bigger incision. Okay, you don't want to leave cancer behind for the sake of aesthetics. So for a beginner, don't worry about the aesthetics, about the length of the incision, or if you have to place a Y incision or whatever. I'm not a cancer surgeon, I'm sure you understand.
Another tip I'll tell you, once you operate, you take a photo and you compare with your second neck. So this way you can improve. Nobody, you can judge yourself, every other case.
Let's start the discussion now. 12 minutes.
Yeah. So basically this dialogue is about the difficulties which I have encountered or any beginner would encounter, and sir will answer how to overcome those difficulties.
Right, sir, everybody can answer. Rahul is there to answer.
As long as you are finished in 30 minutes, I don't have a problem. Anybody can answer.
So we start. So initially there will be fear in trainees and young surgeons, like whenever you are giving skin incision, you may go too deep, so your incision may not be bold enough. You are always afraid about injuring marginal mandibular. No? So sir has already...
I've told traction, counter traction and proper extension of it and a good assistant. This is what is needed. And be careful about the greater auricular and the external jaw. Your flap should be above that.
Yes. That's it. So now vessel handling. So sir, how should be the direction of the hemostat while dissecting vessels?
So you should be parallel to the vessel, right? You shouldn't go perpendicular to it. If this is the vessel, you should dissect along and then you should put underneath and take it up, right? Do not dissect like this, it will go and perforate the vessel, along the walls of the vessel. Be very careful, your line should be proper. You see that if they have got tributaries at the side or not. Use a debaki, lift the tissue and dissect. Don't dissect without lifting the tissue, don't dissect. Inadvertently you'll be injuring the vessels inside. Anything else?
And while dissecting spinal accessory nerve, sometimes the nerve may be structurally preserved but not functionally.
Yes.
So tips about dissecting around the spinal accessory.
Correct. One question I have to ask everybody: how many people think that you have preserved the spinal accessory now when your shoulder is working will be fine? Anyone? I have done a nice dissection and the spinal accessory nerve is preserved. Do you think your shoulder will be fine? See, there is no guarantee that if you preserve the spinal accessory nerve, especially level 5 when you are working, that you might have a very good shoulder preservation. Means the patient doesn't have a shoulder syndrome. The spinal accessory nerve sometimes may have supply from C2, C3 and C4. As we were discussing with Dr. Amit, there's a nerve known as the nerve of Mewbach. It supplies from the C2, C3, C4 and it goes and joins the spinal accessory. You might have preserved the spinal accessory, but you have cut that. So be very careful. If not needed, do not sacrifice the cervical plexus. Right? And do not use inervant cautery over the spinal accessory. Spinal accessory now will have some blood vessels. Retract, do the small diathermy, and then, or you just dissect and remove, just separate it. That's it.
Sir, while dissecting lymph nodes and fibrophytic tissues, would you usually use Edson's forceps or use DeBakey?
You're right. Again, if there's a huge node here, you're manipulating the node, use a non-tooth, not a non-tooth LC, use a Bakey or a DeBakey forceps, so it doesn't injure the lymph node and there will be spillage.
How would you dissect tissues?
Just points, one point.
Yeah.
I think I prefer DeBakey for all my neck dissections. I
Okay,
start
cool.
and end with DeBakey.
That's a great idea.
DeBakey is the same thing as avascular forceps or traumatic forceps. DeBakey was a cardiovascular surgeon, so named DeBakey.
Correct.
How will you dissect tissues around the thoracic duct region?
Now, see, the thoracic duct, one key point is when you're operating, when you're deep down in the neck, when you find the transverse cervical artery and vein, the thoracic duct is just anteriorly to it. So the rule of thumb is, when you see the end of the IJV, put a thumb here. The thumb which is pointing, this area, which is pointing towards your internal jugular vein, that is the area where the thoracic duct is. There is a lot of anatomy in it. It is behind the carotids, coming over the IJV, and it is on the anterior scaling. So as a beginner, you might not identify also where is the anterior scaling, right? So identify the transverse cervical artery and vein, and if you follow it anteriorly, the thoracic duct will be there. So once you put your finger here, do not dissect along the this lateral to this IJV here. Now put a thumb, this thumb area, this fibrofatty tissue, don't dissect. You will not injure the thoracic duct. And don't use cautery there, as he said. You can use wet mop and just wipe the tissue from that area. It will not injure your thoracic duct.
So one point I would like to add, thoracic duct has a very variable anatomy.
Yes.
It can come up to the level 3 also.
Yes.
So it need not necessarily be present at level 4 at the junction of the IJV and the brachiocephalic or transverse cervical trunk. So you need to be very careful when you are doing the lateral border of vein. Use blunt dissection from level 3 if you are a trainee starting your dissection, and then at level 4, don't go for cautery immediately. If you have gained experience, that's fine, but otherwise be very careful.
Does there a thoracic duct on the right side? Is there going to injure anything in the right side? Anybody? There are. The right side of the face, your upper arm and your lungs, all are supplied. There are cases where there is a right side also, the thoracic ducts are there. There are cases reported of thoracic leak from the right side also. So don't think that is on the left side and blind you do a dissection on the right side. Keep it in mind. There are huge lymph nodes or huge ducts on the right side also, and you might get innervation injury there.
Sir, how would you repair if the duct is injured?
So when the duct is injured, normally this patient, for 20 or 6 to 8 hours they didn't have food, right? So there will be a leak, there will be a watery fluid coming out from this area, right? So if you feel that sometimes there's a lot of fat, you cut through the diathermy, the fat is also bonding, it is melting, sometimes it is mixed. The first thing is, if you feel there's a thoracic duct injury, ask your anesthesiologist to give a Valsalva maneuver just to see the leaking is increasing or not. If it is so, don't inadvertently go and clamp and try to do a diathermy and stop it. The fibrofatty tissue in that area, get hold of that, pass sutures or put clips. Atraumatic 40 what I use there, and with fibrofatty tissue all around, I do a part sting like suture and I just suture it. Right? And again, if there is a bleeding, sometimes there will be a lot of blood coming from your top and falling in that area. Clean the area properly, identify the leak. Sometimes there will be multiple leaks in that area. You cannot go and suture everything. So fibrofatty tissue along that area, hold with a forceps and slowly keep on suturing it. Even when you do a neck dissection in that area, if you don't have a leak, also suture and come back. The leak may happen after 3 to 4 days also, you do not know. It's very, very important.
Yeah, I think thoracic duct is something which you really don't want to injure. If you have injured, I just want to add that you can take 40 or 50 proline, that suture, or if you have those Liga clips, you use Liga clips, either 300 or 200 Liga clips. Getting that surely is very important.
Please, read about something. I don't have time to discuss about a drug known as octreotide, which is a somatostatin inhibitor. A lot of literature is coming through that. So a lot of big thoracic leaks can be stopped with that. That's it I can add.
So what precautions should be taken if IJV is punctured and how will you repair it?
Okay, the first thing when you are doing as a beginner, if the IJV got punctured, don't get panic. Don't allow anybody to put the suction in that puncture and increase it more, right? You should have your, I've seen people, they're putting the suction in it, try to control the bleeding, it will not help. What is the most common problem with IJV leaking is air embolism, remember that, right? Suddenly the patient will collapse. If you can ask your anesthesiologist to put the patient in Trendelenburg position, dissect and hold with 2 bulldog clamps and repair the IJV under water. Any leak, any vein leak should be under, any repair in the neck when it is bleeding, you should be repaired under water. You can see your leaks very properly. If it's bleeding, you go and try to repair, and if somebody is sucking, you cannot see. Keep copious amount of water, try to find the leak and then you repair. You have to train yourself with that. And carry a vascular set with you when you are doing your neck dissections. Very important.
What if the internal carotid or common carotid artery gets injured?
Right.
So knuckle, carotid knuckle.
Yes. So suppose you are doing a level 2, you get a puncture in the internal carotid. Again, as Amit told, the literature says there are a lot of chances of getting a stroke or a mortality. So what should you do? So the ischemic time of the brain is around about 3 minutes, I believe. So the repair should be so fast. If you are lucky, then it's good. Otherwise, it's difficult, right? If you are lucky, there is a circle of Willis is there from the opposite side. Nothing will happen. If not, at least I think there is a lot of morbidity, mortality with this procedure.
Time limit to repair this?
3 minutes, I believe. Anybody else? Okay.
What to do if there is communication between the skin flaps which we have raised and the tracheostomy side?
Right now, if you go deep to the tracheostomy side, taking the subplatysmal flap, there are a lot of ooze and blood coming from this side down to your stoma. If your stoma gets infected, inherently the stoma is down near level 4 or level 3. So there might be an infection. Right? One, if there is an infection, there will be granulation tissue. The cartilage once it's destroyed, it doesn't get repaired. It's very difficult. It doesn't get repaired. And big vessels are here. So sometimes you are unlucky, they will be oozing and bleeding from there because the big vessels also will get exposed and will get infected. Right? So try to prevent the tracheostomy site from the neck. Don't do the subplatysmal dissection near the tracheostomy site from the top. Try to keep that fiber fatty with the fascia proper there.
And how many of you have come across gossypipoma?
You know what is gossypipoma? Anyone? Gossypipoma?
Leaving a gauze space inside. So that is gossypipoma. So how many of you have, I'm not asking, you have done, but seen in your department? Okay, sir.
Okay.
Words of wisdom on that.
See, everybody will catch the surgeon. You should have a very good scarf nurse with you. That's it. Gauze counting is very important. Gauze little counting at the end is very important. Try to use a mop as much as possible, but right, and hand whatever. Huh? But it is there. No patient will come and say, "I've rakh diya gale pe." Okay. Yeah, later. Yeah, later, right. Okay. Okay, thank you.
Platisma is deficient. Anteriorly, when you are raising the subplatysmal flap, platisma is present bilaterally. So anteriorly, platisma is deficient. So when you are raising the flap, the 2 areas are important where you can puncture your skin. I think you must have seen whenever you are initially starting neck dissection. So submental area is the most strong for coming out, the artery is coming out through the skin. And posteriorly, when you are dissecting the spinal accessory nerve, so there are chances that it might come out of skin.
While raising the posterior flap also, like he has shown you the supraomohyoid neck dissection, but when we are doing modified radical neck dissection or radical neck dissection with trifurcate incision or Schaubinger incision, the posterior flap, the insertion of the sternomastoid and the posterior flap, it does not have too much of fibrofatty tissue in between. No fascia is there. So your assistant has to pull the sternomastoid towards him, and you have to pull the flap towards yourself, and your dissection of the cautery has to be towards the sternomastoid, and you raise the posterior flap, and that also is the place where you can puncture into the skin very easily. Submental, posterior flap when you are raising over the anterior border of the trapezius muscle, and near the level 2B dissection, near the just below the mastoid.
What will you do? If it is posterior flap here, what do you do with that? Repair? If there is a posterior flap here, do you repair it?
Hello. If there is a posterior flap repair, is it if you are going to elevating the flap and you have punctured the posterior flap, what do you do with that? Repair it immediately?
Put the drain.
Yes.